One of the biggest challenges you face as a medical student is, what should I learn? The instinct is, I'm just going to learn everything. And you can do that. The trouble is, 3 weeks later, you forget everything. So what you should understand is everything isn't equally important. We can all intuitively appreciate there are major diseases and minor diseases. I want to introduce you to a third idea, which is there are foundational diseases. And by that I mean clinical medicine is built on a foundation of basic medical sciences. Some diseases just deeply go into the basic sciences that you've got to understand, or you don't understand that disease. And those are diseases that you just shouldn't know enough about. You have to master. So if I say a major disease, you should know presentation, pathophysiology, and natural history. For a foundational disease, you go all the way back to your basic sciences courses, and you're learning cellular physiology, molecular biology, all those core diseases of immunology and how complement works that you're going to need to understand this disease. And what you take from this idea is everything isn't equally important. Before we go further, every week we're going to talk about ideas that will help you study and learn so that you aren't left guessing that everything's equally important and you should memorize it all. Be sure to hit that subscribe button. A really good example of a foundational disease is cystic fibrosis, because to understand cystic fibrosis, you have to know so many deep foundational ideas. You've got to understand protein chemistry, how we signal with receptors, how different organs are designed for different purposes. Lung, because it's blind-ended, has to have a mucociliary escalator. Well, how does cystic fibrosis do that? No, it doesn't have stickier mucus. You've got to think through, where in the lung is it? No, it's not bronchopneumonia. It's a purulent bronchitis of small airways. So when you go through things like anatomy and cellular physiology, and then you get to drugs teach you molecular pathology. We're going to have an introduction to what a profound need you have for basic sciences if you want to master one of the 3 causes of death that are genetically based. So we do a patient-centered learning. It starts with who walks in the door, form a chief complaint, do a differential diagnosis, and always this, right? Clinical medicine is built on a foundation of basic medical sciences. Give me a mental picture of that. First of all, we start with who walks in the door. All of medicine starts with diagnosis and treatment. I mean, that's the universe. So when I say diagnosis, what I mean is this. What is the presentation? Who walks in the door? And I break that clinical experience into 3 things that works really well. It's not, I just made it up, so you can change it, but it works well. And that says symptoms. What does the patient complain of? It does the physical exam. What are the signs that you are then going to go look for? And then the last is testing. What do you now need to do to establish that diagnosis? And then all the way over here, we have, once you have a diagnosis, you have to talk to your patient. So you should do a mental shift in these 2 circles. You should imagine your mother's best friend in front of you. Can you explain this? And so I'm going to call this natural history. And that actually has a meaning. It says, what happens if we do nothing? Because everything we do has to be based on, is it going to be better than doing nothing? So what are you going to say to that patient? The first thing she's going to say is, what happens to me? Yeah, that's prognosis. Is there anything else we have to worry about that this disease brings along? Yep, those are complications. And then the last and obvious thing is there anything we can do about it? So that's going to be treatment. You notice I haven't specified what that is because we want to leave that open. It could be drugs, it could be surgery, it could be just watchful waiting. So there we have the universe of medicine. But what's going to be so different about what we do is, look what I'm going to do. These are based on pathophysiology. In other words, testing works because your test actually elicits a meaningful problem in the pathophys. When you're treating, you should be treating to fix the problem in pathophysiology. So in really great diseases, it works perfectly. Other diseases, we don't know a lot and it's not as great. But nonetheless, pathophys, when I say clinical medicine is built on a foundation of basic medical sciences, I'm implying diagnosis and treatment built on pathophys. Great. How do we apportion our study and diseases in that context? Well, we are going to say this. First thing is we have major diseases. These are important diseases. There's lots of them. And when I say major disease, I expect you to be able to discuss presentation, pathophys, natural history in detail. That's a major disease. You've got to learn them all, put them into your head. What am I going to see in the physical exam? What test would I do? Why is that true? That's your pathophys. A minor disease isn't that. A minor disease is something you have to know, but you sort of breathe it down to, why do I have to know it? It's just a little story about, it teaches me this, it's going to show up this way, you don't want to miss. It's a minor disease. But what we're here today to talk about is what I call a foundational disease. And by that I mean a disease in which there's so much dependent on deep understanding of pathophys, structure, function, DNA, pharmacology, mechanisms of disease, inflammation. So many elements are involved that it really requires a profound understanding of basic sciences to do the disease. Well, flip that thought. It also means if I want to test, I'm going to use that disease to test and see whether you know your basic sciences. So I thought as an example that we should use cystic fibrosis. It's a disease that's really undertaught. I have tried to talk 3 medical schools into giving me 1 week in the first semester of med school in which all the students stop doing everything else and all we do is spend a week mastering cystic fibrosis. I just know it would be fantastic. Yeah, not a chance. No one's even come close. They'll go, yeah, good for you. But I'm just going to show you why. If you do cystic fibrosis, how many profound ideas you have to understand to explain this disease. So I'm not going to do it in detail. I'm just going to sort of go through some of the basic sciences and show you what you wished you knew. And then I'm going to talk about, wow, can I build a whole patient from this and all the therapies? Well, you can. So let's take a look at that. When I say cystic fibrosis, we're talking about the cystic fibrosis protein, which is the CFTR. We can all do that. Cystic fibrosis transmembrane regulator. Well, right off the top, you can see what question I'm going to ask you. It doesn't say channel. It doesn't say symporter. It says regulator. I guess there's an idea behind that. And when we draw the protein, so here's my cell membrane, it's going to have 3 domains. So right away you can say to yourself, I guess I'm learning some protein chemistry here, aren't I? We're going to have the transmembrane. So this is generally how you draw all proteins, right? You have them closed and then you draw something going across. And then we're going to have the nucleotide binding protein, and there's going to be 2, and that's going to attach to a regulator. And then there's going to be another nuclear binding protein here, and they're labeled 1 and 2. Okay, so this is closed. So let's talk about why we need to know this. Because this is going to require an ATP to come in here and bind it. That's why this is a nucleotide binding protein. The nucleotide is ATP. I mean, we should never let biochemistry people name things, right? Why wouldn't you just call it an ATPase? Well, I looked it up. Well, ATPases are sudden rapid use of hydrolysis. Oh, fine, I got it. Some biochemistry protein thing. But nonetheless, it's just an ATP that's hydrolyzing to give the energy to bind them. We can see this is an ATP that binds it right in the middle. And it's going to do that straight out of a protein kinase A, which, as we all know, comes out of a receptor that's GS-alpha. So right away, I get to start talking about receptors, don't I? So I'm doing protein chemistry, get to talk about how we use ATP as a signaler, and we get to talk about PK, which is going to come in here and phosphorylate these proteins, which is what brings the ATP and the 2 nucleotide binding proteins together. And then what's going to happen is that's going to open our protein. So now I've got an open channel. These 2 guys are bound together by my ATP, and there's my phosphorylated regulatory protein. And what's going to come out here is going to be, look what I'm going to say here, because if you just sort of do it superficially, it's going to say chloride. But it's not just chloride. This is going to be really important to know. It's also bicarb. So it's not chloride, it's anions. And we're going to need that as we go through all of our diseases. Okay, how big a protein is this? This is a huge protein, right? This is 480 amino acids. And when we say to ourselves, how many mutations are you going to get? Well, you'll see varying sources. Turns out there's more than 2,100 I'm not going to learn that. And we say, well, what are the mechanisms we get it? Well, it's all the ways you can imagine DNA going wrong. The one we have to know is F for phenylalanine, 580 deletion. So I'm actually going to lose 3 pairs. I'm going to lose a full amino acid. It's phenylalanine. So now all of a sudden you can see we're going to be able to do all the DNA mechanisms of disease. Because if there's deletions, there must be insertions. I think it's got basically every mechanism you can imagine mutation except translocation, which we'll do when we get to our lymphomas, leukemias. So you can say all of a sudden now we can teach lots of our DNA mistakes and how they work. What's a splice mutation, right? All that stuff. So all of a sudden we're talking about protein chemistry. We're talking about receptors. We're talking about mutations in DNA. But the one we have to know is F580 deletion, and that's going to be a protein that's going to go right here on my nucleotide binding domain 1. Do you need to know that? Not a chance you need to know that. But I just looked it up, so here it is. You can say, but I know it exists if I need to look it up. Where do we find this? This is a protein that we always find on glandular epithelium. And I gotta say, it's really impressive to me how many students don't know what that means. So first of all, let's just go talk about what's an epithelium. I have yet to have a medical student correctly identify that for me. So all of a sudden, we're talking about really fundamental histology. And just to scratch the itch, anything that's exposed to the outside world, and that includes guts and all that stuff, has to have a lining. And that lining, which is your protective barrier, is an epithelium, and there are 3. There's squamous for strength, there's glandular for secretion absorption, and there's urothelium for the bladder and urinary tract. Well, this is glandular epithelium. So when you say, tell me how I think about this, let's just draw that out. So when I say glandular epithelium, you need a picture in your head, and it should look like this. Look how I'm going to draw this cell. There's my first cell. Look at this one. Tight, opens, tight, opens. And these are attached at the bottom onto your basement membrane. So tell me about this. You can see this is my apical portion. This goes into the lumen of the structure. And look what I call this. This is my basolateral. Because you can see here's my base here, but look how it opens up. There's these gaps, so anything can go out the lateral as well as it could go out the base. So when we talk about how does this establish a seal, that seal is always established along the apex. And it consists of my zonula occludens, which is the membranes are really tight together. And then they have to have structural support. So that's going to be my zonula adherens, and that's going to be my E-cadherin in glandular tissue. And then I'm going to have my regulatory proteins, which are my claudins. So you can have tight seals in these cells. You can have loose cells that lots of flow. But all of a sudden now you can say, when I say glandular epithelium, you should have that picture. Great. So let's set this up now for tell me about the CFTR. So I'm just going to do a generic cell, and it's going to look like this. Every cell is going to be powered by the ATPase. So anytime you draw a cell, you just start with that, right? So that's going to be 3 sodiums out, 2 potassiums in. You just start every cell with that idea. Then what we're going to add in is, here's my CFTR. Remember, it's going to have 2 anions, depends on the organ, which is more important. It's both bicarb and it's chloride. And then we're going to vary things according to the epithelium. That's what makes this such a powerful disease to study. It changes with every organ that you're in. You've got to know every organ, and it explains the pathology. So let's just set it up generically. The first thing that's going to have, it's very common in glandular epithelium, is going to be my sodium potassium 2 chloride. Yeah, and you thought that was all thick ascending limb of the kidney, and it is, but there's a different one. That's type 2. Type 1 is found in all this glandular epithelium. Yes, it lets in a sodium and a potassium, but it also gives me chloride. See the connection going up to the CFTR. And then highly variable here, depends on your tissue. There might also be an epithelial sodium channel, depends on the organ. So that sets it up, right? Here comes my chloride. If this is open, this is pKa that will open it related to the receptor that's down here. It opens, and there goes my chloride. And then depending on how an individual cell sets it up, in general, we're going to have by osmosis, sodium and water. And now you can see we've hydrated our lumen. So all these are related to hydration. All lumens have to be hydrated. And so you can see the CFTR is absolutely essential in regulating the water and electrolytes for any glandular organ. Still don't really care. Looks like a lot of basic sciences haven't got excited yet. So let's do that. Let's start with intestine. And we're going to start with the colon. So watch what I do. When I say colon, do I have a picture in my mind? I sure do. I don't ever do an organ. Here's my ascending organ. And when I say, okay, show me how I should think of the organ, you're going to do this. There's my tunica muscularis, and there's my mucosa. So all of this must be my submucosa. Yep, that's the generic view of any segment of bowel. I can see it in my mind's eye. Now then you're going to say to me, okay, show me the epithelium, right? And so for colon, it's going to look like this. Here's my basement membrane, and it's going to look, here's my surface, and there are these glands. And these are called my crypts. So when I draw the cell that we're going to run the CFTR through, you're going to say that's all of these cells right here. These are all my cells along here, and the fluid is going to be all of this fluid here. So let's do our cell. So here it is, intestinal cell. Set it up like we always do. There's my 3 sodiums. There's my 2 potassiums. Here's my CFTR. Remember, it's going to be regulated by a receptor. It's going to be a GS alpha. That's going to be my pKa, and that's going to phosphorylate my regulatory and binding proteins and open it up. And it's going to produce chloride and bicarb. And you got to know which organ you're in to know which you care about more. Because we're in colon, we're going to add in our sodium potassium 2 chloride. And so I'm going to get my chloride here, and that's how I can do that. We're going to get our water and sodium by osmosis. And so now I've hydrated my bowel. Great. Do I care? Well, actually you do. Look what I'm going to say to you. Supposing I had Vibrio cholera toxin, and there's another one just almost like it, which is going to be from my enterotoxic E. coli. Supposing that captured the G alpha and gave it a gain of function that increased my pKa, that left this permanently on. That's going to give me those pathogenic diarrheas. So what happens when we have cystic fibrosis? Well, in cystic fibrosis, we lose the CFTR. It's non-functioning, which means I'm not going to have chloride, which means I'm not going to have sodium or water. Make me care. This is going to be my meconium ileus in my newborn, and in general, constipation for my patients. Wow, right? You got to admit, that's a pretty good story. And what we can do now is we can go through all of the key organs in cystic fibrosis and draw a similar story. So now all of a sudden I have to draw all the organs that matter. The next one's going to be lung. And I'm not going to go through all the details. I'm going to set up to show you how to think about lung, and then you can say, wow, I really need that cellular physiology to understand what's going to happen. So when I say to you lung, how do you think about lung gross anatomy? I want you to think about it this way. Here's my laryngotracheal bronchial. Let's draw larynx in here. Then I have my bronchi. Remember, these have cartilage and glands. Then I'm going to do my bronchioles. These are my terminal bronchioles. They don't have glands and they don't have cartilage. And then I come down to my terminal respiratory unit. You can just call it the alveolus. That's perfectly fine. And now you can see I've got ventilation and respiration. So where do I think about cystic fibrosis? It's going to be right here in the small airways. Well, what's that going to look like? Well, we're actually, just because it's a better story, I'm going to actually do a small bronchus. Let's just call it a segmental or subsegmental bronchus. And it's going to look like this. Here's my epithelium on a basement membrane. And remember, this has glands. The other thing we want to make sure we remember is this is ciliated, pseudostratified, ciliated columnar cells. What's the problem that lung has that intestine doesn't? Intestine has a hole in and a hole out. So when we want to move things through to prevent buildup and overgrowth, it's pretty easy. You just do peristalsis and pass it out the other end. But what do you do if it's a blind-ended tube? And the answer is you actually start here. Everything down here in the alveolus has to be macrophages to lymph nodes, but everything up here is a mucociliary escalator. So how does that look when we actually draw it out? Well, you're going to start here with a watery layer of mucus. And notice what I'm going to draw here. Pay attention. Just the tips of my cilia stick above it. Most of this is going to be watery. The second thing we're going to have is going to be a gel-like mucus. So this is going to have a name, and you notice it's going to be different than the way they teach it in school. This is called my ASL. So this is my airway watery layer, and it's broken into two parts. This is a gel-like mucus, and this is a watery mucus, which is called periciliary because it's around the cilia, but it's also got an old name called the sol. So you can appreciate now the gel, which is viscous and sticky, traps everything, but it's sticky and viscous. So it floats on this watery layer, and it's this watery layer that's just catching the tip of that gel, and that gel is floating friction low on the watery layer. Well, where did they come from? Well, you can see we've got two stories here, don't we? We've got the surface epithelial cells, pseudostratified ciliated columnar, and we also have these glandular cells, and they come in two types of cells. Most of these cells are going to be mucus-producing cells, but some of them are going to be this watery sol layer. So which is which? When we talk about the gel-like layer, this is going to be 80% coming from glands. But when we talk about the watery layer here, this is going to be mostly 70% of the surface epithelium. So you can see then when I draw the cell for the lung, I'm drawing that superficial epithelial cell because that's the bad problem, is the sol layer, not the gel layer. So this is about the surface epithelium. And so we're not going to go into the details. That's, this would go on forever if we didn't. But what you're going to see is if I have an abnormal CFTR, then I'm not going to get my sodium and water because I don't have any chloride. And this is the layer that you're missing. You're missing the periciliary watery layer, which means the mucus drops on the cilia and they can't move it. It's molasses. So when people tell you they get thick mucus, that's just not a good way of thinking about it. You should think about the gel layer floating on the watery layer, and when it is gone, it drops on the cilia and no one can move it. So look at how we do a ClinPath correlation on this. So what am I going to see in my patient? Well, the pathology, no kidding, is in the small airways. Can you see where that is in the lung? And so this is going to be in the small airways. This is a purulent bronchitis. It's not a pneumonia. No, this is pneumonia down here in my alveolus. This is not bronchopneumonia. This is a purulent bronchitis because that's where the mucus is stuck on the cilia. And over time, this is going to become my bronchiectasis. And because you can't move that mucus, you get these really unusual flora phenomenon. You can think of this as my Pseudomonas aeruginosa, but it's a whole polymicrobial mash. And they're going to form biofilms. So when you take a look at this disease, you can see where to put it, you can see what the pathology is, you can start adding in your organisms, and you can see the progression of pathology. So you're starting to get the sense of how we can do a foundational disease. Think what you have to know. We've already discussed you got to know your DNA and your various mutations. You got to know how proteins work. You got to know how receptors work. And now we're going through the various tissues. I've said, do you understand how intestinal water works? Do you understand how the lung has a mucociliary escalator? The two other organs that we would talk about if we had more time is we'd say, how do you think about the exocrine pancreas? Because you got to know how that works at the gross cellular and cellular physiology level to understand what happens when the CFTR breaks. The other organ you got to do is the sweat gland, because the sweat gland is going to totally flip which way the chloride goes, because it's a regulator, not a energy-driven pump. We could spend a lot of time. Think how many organs you have to know to reasonably discuss cystic fibrosis. And then we move on to the bonus here is we move on to natural history. Because you notice I haven't talked about protein synthesis yet. But you can see what I'm going to do now. I'm going to talk about DNA, making this big, long protein, 480 amino acids. We're going to go to transcription in RNA. And then that's going to end up here in my smooth endoplasmic reticulum. And now we're talking about folding, because misfolding is a big part of the pathology. And then we're going to talk about trafficking, because it has to go from the endoplasmic reticulum, it's going to get packaged in the Golgi. And then it's going to go to our surface epithelium, and here it's going to be sitting on the apical surface. And the question is, does it function? And does it have a normal half-life? You actually have to be able to talk about how proteins are made, packaged, transported, and functioned all the way through. And CFTR is a fantastic disease for doing this. In fact, because there's so many mutations, these are actually all got various class types. To pointing out defects, some mutations have been found in all of them. And then we come to what's really changed everything. We've come to treatment. And this is going to be the drugs that are the CFTRs. And they have revolutionized how we think about this disease, because this is going to change how we do the protein. And it's going to basically go to two fundamentally different functions. We're going to have those that affect the potentiation, meaning this is going to be basically what is the likelihood that it's going to open properly, which is why we kind of had to know how the protein worked. And the second we're going to have to do is the correctors, which is basically going to be, do we have enough of the protein and does it traffic well? And the miracle has been, if you use all three, if we walk through the F580 deletion, it has multiple problems in multiple areas. Mostly here, it's misfolded and doesn't get out. That's its single biggest problem. You have to use all three for the commonest mutation that we find. So you can see how, for a beginning medical student, we could spend a week studying this, each step, each problem, in profound detail as a basic way of thinking about how are proteins made, how are they trafficked and packaged, how do they work, how are they regulated, is it different in every epithelium? Can you explain mucociliary escalator in lung? Can you explain the difference between the acinar cells and the ductal cells in pancreas? Tell me about the straight resorptive part of a sweat gland versus the secretory coil. It just goes into this deep idea of, can you think in organs and tissues? So I want to end on this idea. When you're studying your diseases, you should think about those diseases that are so important that they are foundational. There really isn't any book or source to do that, right? How is a medical student supposed to know that? Well, that's kind of why we're here, right? I spend a lot of time teaching, and when I teach, I go from patient to disease, and I have to keep reteaching basic sciences because the foundations aren't there. So I love foundational diseases. I always start with them. Like I always start every organ system with failures. Oh, so foundational. Then we talk about the major diseases. When you're studying a disease, how well should I know it? Presentation, pathophys, natural history. Yep, you should know all of those, be able to discuss them, conversant in all. And then what are the minor diseases? Yeah, tell me why I care. It's usually some small important point like, well, it teaches us. So for example, follicular lymphoma. Everything we know about apoptosis started with the overproduction of BCL2 in that disease. So what should I know about follicular lymphoma? Well, you should know about BCL2 because it's our walk into apoptosis. So that would be a minor disease. So that brings me to the end of this discussion. Everything isn't equally important in medicine. The diseases that matter the most for your step 1 exam are going to be diseases that have foundational build-outs to them. And what are they? Well, come on, we talk about them, and obviously cystic fibrosis is wildly undertaught as a foundational disease. Major diseases are pretty straightforward. Give me an example. So I think gout. Gout is a major disease. It doesn't have any great pathophysiologic principles. I guess I could drag out the inflammasome. But basically, it's just like crystals form, they bring neutrophils, they hurt, get rid of the uric acid. I get it. That's a basic disease. You should know that. That's really different than, for example, I say SLE, because lupus is our model disease for type 3 hypersensitivity. Oh, I'm going to get into antigen antibody complexes and complement and all that discussion. It's going to get into glomerulonephritis, telling you about the filtration membrane, and so on, foundational ideas. So don't think everything's equally important. When you go to your first aid, and yes, we all go to first aid, you can say, what do I have to know? But as you go through your diseases, say, I have to leave first aid because I've got to know this as a foundational or major disease. So in discussing cystic fibrosis today, I'm sure you appreciated I only sort of introduced some of the ideas you need to know. Clearly, we didn't do many organs. We didn't talk about how the proteins are trafficked. We didn't talk about the actual molecular level that the drugs work at. There's a lot more to talk about. Please don't think this is the entire discussion. It's merely to let you understand, wow, I've memorized a few random facts about cystic fibrosis. I really haven't mastered the disease. If you want to see how you're doing, we offer you a free series of multiple choice questions. They'll show you what clinically based learning is. And so you can try them out and they come with explanations and you can see how you're doing in patient-centered learning. You can check that all out. It's linked in the description. We'll see you next time.